I'm Dr. Jam Kothari.
And I'm Dr. Sally Moore. And this is a Myeloma Minutes, a podcast for people affected by myeloma, patients, friends and family.
Sally, good evening. It's 10 p.m. on a Sunday night and it's still 46 degrees, 100% humidity. I've broken all the fans in the house. How are you guys getting on with it?
Yeah, no, we're great. I mean, it's like cold bath territory, isn't it? It's properly like tropical. That's how I would describe it. The humidity as well. But no, otherwise grand, Sunday, things are cooling down. Life is good. England and the World Cup, It's that time of year. We're doing all right. We're holding our own. So life is pretty good. Not going to complain.
No, absolutely. Actually, when you think of the heat, I do think of the people with myeloma a lot, actually, because actually there's quite a lot to think about, right? In good weather, before we get into the topic of today, actually, when it's really hot, like our patients must stay hydrated. Like it's amazing, right? So how often you'll look at people's bloods when it's hot and they can be a bit off. I'm the same. I mean, everyone forgets to drink, right? So that's the first thing, right? That's really important. And people on certain medications like lenalidomide, we know that some chemos, len, other things make people very sensitive, literally by the factor 50.
I completely agree. I was just telling you that I popped into A&E this weekend for gory reasons I won't go into, but actually they did share with me, it's extraordinary how many people are presenting, having not just thought about what you need to do when it's hot. And I think particularly for people with myeloma, being hydrated is important, but also when you're fatigued for whatever reason with the disease, it compounds that so much. So I think it is a difficult time. We all love the sunny weather. It's amazing. But yeah, totally. To our listeners, just pay attention to how you're feeling and ask your loved ones to pay attention as well, because they often have a really good insight as to how you're getting on.
Yeah, no, very much so. So Sally, today we're going to talk about chemotherapy. Yep. We're going to talk about a very specific type of chemotherapy that we have to use in certain situations in myeloma. And it's with some old drugs, actually. We've spent a lot of the last year and a half talking about the newest immunotherapy and the clever ways in which new drugs are really helping our immune system to fight cancer. But what we're going to talk about today is, it's actually a little bit old school, isn't it?
Yeah, definitely. I mean, the new drugs are amazing and they are changing everything. And I think we've spoken about that a lot. So it must come as a surprise to a number of our patients, maybe not the majority, but still a significant few, where actually they come and see you or I, Jam, and we say, hang on a minute, we need to change tack a bit. This new drug was great, but we need to improve on that further. And we need to go back a step to use more old-fashioned regimens. So I think it is really important that we explore that, why that's so important, when we use it and what that might mean for somebody.
Chemotherapy has been around sort of 70, 80 odd years now. As it's developed through the decades, those first drugs that worked in cancer, they're toxins, they're chemicals, but they're very good at killing sort of cells that are growing relatively quickly or fast-growing cells. So you get kind of this sort of, anti-cancer effect. But of course, there are lots of cells in the body that are relatively fast growing, but not cancer cells. And so many people, understandably, over the years and still now, are so scared of chemotherapy because for them, that chemotherapy means sickness and vomiting, hair loss, of course, bad problems with, your bowels and other sorts of symptoms like that. That's because these older sorts of chemotherapy are not as sort of smart or targeted. But at the same time, then there's this combination in particular that we're really going to focus on today, and that's called DTPACE, or DPACE, and the variations on the terminology, which combines a few of these drugs to basically give the myeloma a short, sharp shock. Really, I think is the best way of putting it.
DTPACE is a particularly potent regimen which has been around for a while. But before we delve into that, Jam, something which I often find in clinic, which is really confusing, and maybe we've spoken about it on previous podcasts, but I do think it's worth us just exploring once again, is actually chemo. What is it? Because actually, I think there's a general consensus, a general understanding that if you've got cancer and you're having treatment for cancer, that is chemotherapy. And I think in layman's terms, that's true. But when we talk about chemotherapy from the medical perspective, I guess we can also use that terminology. But in this situation, we're referring to those, like you say, those old-fashioned drugs, the ones which just obliterate everything in their path, which is growing quickly. And that really is chemotherapy. Whereas the newer drugs we've explored on other podcasts are perhaps more targeted immune therapies. And so there is that difference. And I think it can be really confusing to people It's like, well, I'm on chemo. Well, you are, but you're sort of not. Well, with this regimen, you definitely are on chemo. This is the old stuff, which we've been giving for decades, and we still give because it really has an important place in the sort of treatment pathway.
Over the pods, we have touched on drugs like this before, because also, an autologous stem cell transplant, this drug, melphalan, that's one of these old style chemo drugs. You lose your hair, it makes you feel, really rotten and sick, but you can get rid of a lot of leftover myeloma, and it's still an important part. But sometimes you have to use drugs similar to melphalan or a mixture of similar overlapping combinations to get control back of myeloma when it's behaving in sort of very particular ways.
Definitely, because as those cells grow quickly, and we particularly employ these agents when things perhaps haven't gone as optimally as we'd hoped, it's a different approach to controlling the myeloma where the novel therapies haven't quite cut through in the way we hoped. You can go back to the old-fashioned drugs. They can target, as you said, those faster-growing cells. We still use combinations of drugs because the drugs work together more effectively than they do separately, and they can calm down those cells. But we give that for a short period of time as a bridge, basically, to the next thing. And I think that's how these older agents, these older chemotherapy regimens are best employed. They're
kind of given often between 1 and 2 months, as you say, to try and really give the myeloma a short, sharp shock. It can be especially useful in people potentially when the myeloma has grown outside of the bone marrow, and it's there as a bridge, as a segue to get to something else.
Yeah. Definitely, exactly. Rather than long term, you're going to be on this for ages. Particularly, I think that makes it easier to talk to people about, because it's like, actually, even if you do feel a bit queasy with this, and I say a bit queasy because I hope that we've got decent anti-sickness medication, for example, to calm down any feelings of sickness and so on and so forth. Whatever the side effect profile might be, it tends to be short-lived. As soon as the treatment's flushed through your body, you should begin to feel better, and that therefore might be a relief. It might make it easier to handle.
The specific combination that we're going to, spend most of, the next 10 to 15 minutes talking about is this combination DTPACE. And I'm just going to sort of mention the names of the drugs because some will be familiar. The D is dexamethasone, our old frenemy, which is certainly part of this treatment combination. The second drug is actually thalidomide. So actually, this is where, we've been talking about old school drugs, but this is an immune modulating agent, immunomodulatory agent, which is also part of it. So this kind of helps the faster drugs and the dexamethasone work together. And then the 4 drugs, the PACE, Sally, what makes up the PACE?
Yeah, so the PACE, each letter stands for a different drug. But here, just to confuse matters further, the drug doesn't begin with P necessarily or A or so on and so forth. But anyway, so the PACE is PACE, but it actually represents cisplatin, which begins with a C, doxorubicin, which begins with a D, cyclophosphamide, which does begin with a C, and etoposide, which does begin with an E. So 4 different drugs. They all have got lots of different names, hence the spelling confusion. And these are drugs which are also used for other types of cancers, particularly blood cancers, but indeed actually for other types of cancers in the round, because they have, as we've already said, that broad cancer effect.
They're used quite a lot in conditions like lymphoma, ovarian cancer. And depending on where you are in the world and the nature of your myeloma, instead of the thalidomide, you might have lenalidomide. Sometimes you can add our old sort of, again, friendly drug Velcade to it as well. But it's the PACE bit, which is the older style of chemotherapy drugs, those drugs that basically, look and say, well, these are fast growing cells and I can kill these. We've talked about the different ways in which drugs are given. But when you use these drugs, these PACE drugs, they're giving in a very specific way because they're all given intravenously, but they're all given very, very slowly for many hours, right? A number of days, a fixed number of days, which is, again, is very different to how we give really any drug in myeloma.
Yeah, definitely. They sort of tend to be infused over many, many hours. And that is different. So people are often hooked up to a pump, or because it's a long-term or a longer-term infusion, need to be in hospital to receive these drugs. And that's just because that's how we understand how they work. It also, means that the kidneys have time to filter the drugs as they go into the body, and the liver and so on and so forth. But yeah, it's a protracted administration that often requires being admitted admitted to hospital. In some centres, particularly in the UK, and I suspect over the world, people can what we call ambulate, which means they can go home with a pump attached to their body. But in the majority of cases, you have to be admitted, you have to be hydrated. And actually the good thing about that is if you get early side effects, you've got a clinical team around you who can get on top of them. They can start the right antisickness medication. They can make sure you're getting enough fluids, for example. So just keep a closer eye as this combination trickles in.
Yeah, because like three of the drugs out of the four, actually, you're going to be attached for 96 hours. Yeah. So literally 4 days. So these drugs have been developed sort of drip in very slowly over that time. And a fourth drug, is given as, again, intravenously as a quicker shot. But it's like people are often, very much hooked up. Yeah, they have often this thing called a PICC line, which is a long plastic line that we've spoken about before that people have during transplants. But that allows drugs to be infused safely and very slowly. And then sometimes you have another chemo drug going on the other side as well. Yeah, it's just a different style of approach, but allows the drugs to do their job.
Thank you for listening to the Myeloma Minutes podcast, proudly partnering with Myeloma UK. For more credible myeloma-related material and support, please visit the Myeloma website at myeloma.org.uk. That's myeloma.org.uk. Or call the info line on 0800 980 332, which you can find in this episode's description. The side effect list, there's a lot. It's a bit like people come to clinics, don't they, with their list and their little box of side effects. And we all know that list is really long, even if you're on what we might consider to be a relatively benign treatment. And so when you've got these stronger treatments and so many of them together, the list of side effects is extraordinary. It really is. But that doesn't mean that you're necessarily going to get them, which is incredibly important. But suffice to say, some of the drugs come with particular side effects. So, for example, the C drug, the cisplatin, which is actually a P in this case, that can sometimes impact on your kidney function. And so we monitor your kidneys. If you were to inadvertently, accidentally get too much of it, sometimes it can cause some blood loss through the bladder. So you might be monitored for that. The doxorubicin drug, we have to be careful that your heart's in good shape before you start that treatment. So, because actually if you have too much of that, we know it can, in some people, affect the heart. In most people it doesn't, but we certainly keep an eye on that. And cyclophosphamide, which we actually do use in other myeloma combinations, can sometimes cause hair thinning, again, can affect the bladder and can make you feel sick. And the etoposide similarly. So really, they're sort of like, as you said really at the beginning, Jam, old-fashioned side effects, aren't they? Feeling queasy, losing your hair, thinking about how your organs are functioning, rather than a more tailored side effects like the bile salt malabsorption you might get with lenalidomide. These are very sort of generic toxicities, not pleasant, but hopefully we're very familiar with them and therefore they're very manageable.
Absolutely. And when you combine all these drugs together as well, they really hit your immune system after a period of time. And there's this risk of infection. But again, the way in which drugs, have been given for so many decades in all sorts of cancers is that you give a cycle of treatment every 3 to 4 weeks, and then your immune system sort of drops in the middle of it. And, there's a high risk of, potentially serious infection that requires hospitalization with that kind of approach. And that's pretty similar for this. So, these drugs sort of go in for that first, few days you're attached. And, we really need to make sure that people are on the right anti-sickness medications, which is really important. They don't get sometimes constipated because of the anti-sickness medications, but then get other bowel disturbance or a sore mouth. But then 10 to 12 days later, blood counts can drop and people can be at real risk of infection, and they may need, blood transfusions or platelet transfusions. And those GCSF injections that we, have spoken about in other pods, to just try and keep the immune system up.
Yeah.
So they're things that you have to think about just sort of a couple of weeks in. But actually, when you're starting out, you've got to get those initial bits right. As you mentioned, kidney function, very important, Sally, which can be a big issue with some of our patients, and you will have to adjust the dose or, sometimes substitute for a similar but different drug. On top of that, you might have, you'll usually have sort of 4 days of, steroids at the beginning and a drug like thalidomide or lenalidomide to go alongside. So, it's a lot. And to be honest, if you're listening to this and you're just about to have DTPACE, if you use DTPACE, and it's a hard thing to say, but it's important. It often means that things aren't going like we wanted it to. And I think it's important that we do say that.
Yeah, it's so true. I think DTPACE, the way I approach this regimen, for example, there's a sister regimen which contains very similar drugs, which has got a different acronym, ESHAP. So if you're on DTPACE or ESHAP, the two are very similar. How I view it is it's almost like a stem cell transplant in terms of how we manage the toxicities, the side effects you get. And that's because the stem cell transplant contains old-fashioned drugs, but it's also often used as a bridge to stem cell transplant to pull the myeloma back under control where we may not have had the best response. We may not have had the decent fall in the paraprotein or the light chains, or in some instances, those numbers may have changed and come down, but then pop back up. And so you want to go in with something different before you move on to your stem cell transplant. So I think that's really where DTPACE or the sister kind of regimen, ESHAP, has its place. And it is because in an ideal world, you'd want to have controlled the myeloma, brought it down, kept it down before you move forward. And this is something we just put in between when it hasn't quite gone according to plan.
And it can be highly effective, and it's quite neat sometimes as well, because of course you need to collect stem cells for a stem cell transplant, and you can actually use this chemotherapy regimen as part of that, because these drugs help move those stem cells partly into the blood, and you can give slightly higher doses of those GCSF injections, and actually the chemotherapy has its sort of anti-chemotherapy effect, but then a couple of weeks later, you can actually, get the stem cells out by people going on one of those stem cell filtering machines. So it's actually can have a dual purpose as well.
Yeah, two for the price of one, hey Jam. I mean, that's looking on the bright side, isn't it? But, it is useful that we can do that. And of course, where we are doing that and we're collecting stem cells, we're doing that because we're moving into a transplant. And so it might be actually you can move forward with your transplant pretty soon after, which is also a win because you're sort of moving forward and things are moving back again in the right direction.
Certainly what you've just described is very much one of the main established reasons to use DTPACE. Now, you can actually use it sort of later in the myeloma journey as well, perhaps use a little bit less, but the key point is it's used as a bridge. Now, an example I would give for some, patient I saw last week, for example, we were hoping to get the patient to the point where we could give them CAR T therapy. You need to give bridging chemotherapy. We spoke about this in the CAR T pod, and we know that CAR T works better if your disease is under control. For a variety of reasons, the first thing we tried didn't work very well. The patient had myeloma outside of the bone marrow, and I thought we need to try something that can control the myeloma so the CAR T has less to do, and we know it's safer if your myeloma is under control. So we gave just one cycle here of this PACE combination, works extremely well. And, patients coming in soon for CAR T. It doesn't have to be CAR T. It can be used as a bridge to other types of treatment as well, other immunotherapies. There's less data and evidence in this space. It still has a role. And even though we've had all of these, amazing advances over the last few years, we still have to reach sometimes to the old school to help us out.
Definitely. And it's great that we are able to do that, I think. So for our listeners and their families, it may be that your doctor never talks to you about this combination because it's simply not necessary for you, because we don't recommend using this for every patient as part of the pathway for treating myeloma, because many of the drugs which we now use are much better at controlling the myeloma with fewer toxicities. But as we said at the beginning, it still has a role where, particularly, as you've said so beautifully, Jam, you just want to use it to get you to somewhere else, which may be the bigger picture. It sort of has a really important part in that bigger picture piece. So don't feel like you're missing out if any of our listeners are like, hang on a minute, I haven't heard about this. And why hasn't anyone spoken to me about it? That's not a bad thing. And for those of you who've been through it or are going through it, you will be okay. And what's ahead of you will hopefully really consolidate the gains of this regimen.
Yeah, and I think it's really important, Sally, for all of us to, I think, understand and remember that there are things that we sometimes have to use that can still play an important role. Everyone likes shiny new toys, and we're the same, and they can be phenomenally effective. But sometimes doing things that we've had to do historically, can still have a role. And it's about looking at the breadth of treatment available, because, I think, as we've said, everyone's journey is unique, and it's about finding the right tools at the right time, which we can't always do. But the reason that, Sally, we were talking about what are we going to chat about on this Sunday? So I've had probably 3 or 4 patients start DTPACE over the last month. A couple in that situation that you just said, where the first treatment, that induction treatment, getting to transplant hadn't quite controlled the myeloma and it had become more active. So giving the DTPACE as a bridge to transplant, and sort of 2 people in the relapse setting, trying to get them to a sort of a decent immunotherapy option, basically.
Yeah, definitely. And I think for our listeners, what's also really important to say, and for those regular listeners, you'd have heard Jam and I speak with huge optimism about what's ahead. And goodness me, that is credible. And to the point where actually so many conversations we're now having in the myeloma community about pulling back on treatment. But it's also really important to say, as you've just pointed out, Jam, everyone's path is different. The disease changes as you live with it. And therefore, we need to adapt. And one size does not fit all. And this is just another tool in the toolbox, to use an analogy, to help control the myeloma. Now, one would hope in the future we'll be able to figure out with greater sensitivity, with greater accuracy, this treatment is going to be fab for this patient, so they don't need X, Y, or Z, or this treatment is going to be just the job. But it's still the case that to some extent, most people start off on similar treatments at the beginning, but because they don't work perfectly for everybody, because the disease is so different, being able to employ something like DTPACE can overcome what we call, the fancy word for that is that heterogeneity, but what it means is just basically the difference in how the condition can behave.
If you're, listening to this and you've either had DTPACE, well, then hopefully you don't want to think about it too much, but you identify that it was a punchy combination and you got side effects, but it got you to a place where other treatment can control it. If you're about to start it now, ideally we wouldn't have wanted to go down this route, but it's an important tool and we're still trying to get you to that point where the myeloma is controlled. And in the vast majority of people, the treatment is tolerable. Just make sure that your doctors use the right anti-sickness medications, you stay hydrated, you're very watchful for that risk of infection as you sort of move into, a week or so after the treatment, and you'll hopefully get to the place where your myeloma is better controlled and ready for the next option to try and make that myeloma as well controlled as possible.
Definitely. I mean, as I'm listening to you speak, Jam, I'm trying to think about a sporting analogy, because it's such a sporting time of year, isn't it? It's a bit like when you've gone off track, you're not quite on the same path as everybody else, but you need to get back on that path. You need to get back on track. And this is what DTPACE can offer, just get you back to where you need to be.
Thanks, Sal. It's been really good chatting about this today. I look forward to some of the next podcasts. It's been a very busy summer season of conferences, and actually there have been some very exciting advances shared at big American and big European meetings. And our next pod is going to be with, one of our good friends, Dr. Charlotte Paulin, who's sort of an internationally recognized expert in myeloma. And she's going to be joining us to talk about that. So I'm really looking forward to that.
Yeah, can't wait. And lovely to see you, Jam. And please get in touch if there are any questions, everybody.
Thanks, everyone. And we will see you at the next one.
Bye.
This has been the Myeloma Minutes. We hope you found this week's pod engaging, interesting, and above all, understandable and genuinely useful. If you enjoyed today's episode, please follow the podcast and share it with anyone who might benefit, from your online support group, your medical team, to friends and family. And as always, if you have questions or topics you'd like us to cover in the future episodes, please do get in touch. You can find us at www.themyelomaminutes.com or email us at themyelomaminutes@gmail.com. And you can find us on social media by searching The Myeloma Minutes on Instagram and Facebook. Many thanks for listening, and we'll see you at the next one.